Okay, I will get started. It looks like we're at a good number. I'm going to be kind of juggling here, so if my eyes go off the screen, it's because I'm letting people in. So thank you everyone for attending. This is going to be our last Club EvMed for the semester, which really just means we're going to be giving it about a 5-6 week hiatus, and then we're going to kick off again in July, we hope, for another session, and then looking at a keynote speaker for ISEMF to kick off the fall semester. So thank you guys for being here. Welcome to Club EvMed. My name is Johnny Ullman. I'm the assistant director for TRISEM. And I should recognize Lucas Blumrich. He is our colleague down in Brazil who actually organized this session, but his internet is a little unstable, so I'll be doing the moderating and introductions. Our goal here at Club EvMed is to connect the evolutionary medicine community and then share our exciting new research with colleagues like Makenna and Mary. We try to have this as informal as possible. We really want emphasis on the discussion component, and we love that dialogue and to get different people's perspectives. So that's why this is officially called the Club EvMed Conversations. Also, Club EvMed is organized by ISEMF, the International Society for Evolutionary Medicine and Public Health. I had mentioned ISEMF is where we're going to try to have our keynote give a talk for the next session in August. If you aren't, now is a great time to become a member, so renew your membership. Also register for ISEMF 2024 in Durham, UK, August 6th through the 9th. Club EvMed is organized by, we're happy to say, 10 evolutionary medicine centers and programs. Our newest collaborators, represented by Lucas here, the Brazilian Evolution Health Study Group, which is down at the University of Sao Paulo, as well as the University of Kiel and the Kiel Evolutionary Center and TransEvo, as well as the University Studies Group at Vanderbilt. So what we're going to do here is we're going to have Makenna and Mary begin their talk, and we're going to try to hold questions until the end. However, if you really do have any kind of burning questions, please put them in the chat or raise your virtual hands, or you can message me offline if you'd like. But we'll try to queue those up and introduce them kind of in order as they come after Makenna and Mary are done. Please feel free to tweet about us using the hashtag Club EvMed. And then I will also paste in some key information as well in the chat after I get done here. But now it's my pleasure to introduce Dr. Mary Shenk and Makenna Lenover. Their title of the talk was going to be an evolutionary medicine approach to lifestyle-related factors and causes of irritable bowel syndrome. Makenna is a PhD candidate from Penn State Department of Anthropology. She works with Dr. Mary Shenk, and she holds an MPH from the Penn State College of Medicine. And she is interested in irritable bowel syndrome and how lifestyles and culture contribute to chronic diseases, investigated by a quantitative and qualitative survey design methods. And Professor Mary Shenk is an associate professor of anthropology, demography, and Asian studies at Penn State. She's interested in evolutionary approaches to human behavior, demography, and health. And they are both attending ISEMF this year, and it's going to be great to connect with them some more. So with that, it's my honor and privilege to hand it over to Makenna and Mary. Thank you.
All right. Thank you everyone for having us. We are presenting our research in evolutionary medicine approach to lifestyle-related factors and irritable bowel syndrome. This is actually my dissertation work, and we'll begin the talk presenting some published research and then kind of end it looking at our future directions and a project that's been ongoing, and would definitely welcome any feedback or input everyone has. So we as anthropologists have recognized there's an increasing rate of non-communicable diseases across the country and across the world, and this has been an increasing concern in public health, as well as medicine, with treatment and prevention. One chronic disease that hasn't been as well dissected within the anthropological space is irritable bowel syndrome. Irritable bowel syndrome, or IBS, as you'll hear me refer to it probably the rest of the talk, is a functional gastrointestinal disorder with the core symptoms of abdominal pain as well as changes in bowel habits, so constipation or diarrhea. What's really interesting about IBS is how every patient has a very distinct, unique illness experience. So someone may have symptoms for a few days, a few weeks, a few months, or someone may have very extreme symptoms one month, very mild symptoms the next. Symptom presentation can vary between constipation and diarrhea, or just one or the other, and it can change throughout a patient's life course. There's also really not many good cures for IBS at this time. The best treatment measure, which we'll talk a bit more about later, has about maybe a 60 to 70% effectiveness, meaning there's a huge gap for both treatment and prevention. So the rates of IBS are rising. Within the United States, there's currently about a 20% IBS prevalence, and there's currently about an 11.2% global prevalence. We see the rates of IBS rising in newly industrialized countries and can track the rates of this illness to countries increasingly adopting an industrialized lifestyle. When looking at irritable bowel syndrome, there is a very rich clinical literature. People are perplexed and fascinated by this illness, and if you just take a quick Google Scholar search, you'll see about 500,000 hits. Within the gastroenterology space, this is very well researched, but unfortunately, this research is very siloed, meaning that they may look at one specific treatment or one very specific risk factor rather than trying to understand what ultimately is causing IBS, therefore trying to translate that to treatment. We felt that IBS really needed a strong linking theoretical narrative to disentangle all the complexity and conflicting reports and also allow us to identify ultimate explanations for the illness. This brought us to evolutionary medicine. So first, we conducted a scoping literature review, which is published in Evolutionary Anthropology. What we did was we started to sift through this clinical literature, trying to understand the risk factors specifically related to environment and behavior. We started at about 4,000 papers, ended up with about 1,000, and really went through these and categorized them into what we identified as 5 sort of core behavioral domains that were identified to be related to irritable bowel syndrome, but also through an evolutionary medicine approach we know are associated with industrialization. This included nutritional shifts, increased hygiene, increased sedentism, changes in light-dark cycles, as well as increased emotional stress. Those sort of behavioral domains can lead to a lot of illnesses. So to better understand by how these domains lead to irritable bowel syndrome, we identified 3 broader sort of biological mechanisms or the proximate causes for IBS, including digestion, the immune system, and the brain-gut axis. And we'll talk about all 3 of these. Starting with digestion, as I told you, irritable bowel syndrome is a functional gastrointestinal disorder, meaning that something is going wrong with the digestive tract. So the food entering the digestive system would seemingly have a role to play in this illness. And looking at the clinical literature, this is one of the best researched elements of irritable bowel. People are very much interested in trigger foods and elimination diets. What we found when sorting through all of this information was that the foods that were consistently identified as either trigger foods or foods to eliminate in a diet to treat symptoms were also foods that we saw an increased consumption of across the nutrition transition. This starts with increased gluten and lactose consumption and moves into this decrease of fiber and fresh foods that we see in industrialization and post-industrialized environments, the level of additives that are being put in the food, an increased consumption of alcohol and caffeine, and increased FODMAP consumption. So FODMAP is an acronym for a very long set of highly fermentable carbohydrates. These don't digest within the upper GI. They make it down to the lower GI, and the gut bacteria love FODMAPs. They eat them, they ferment, causing lots of gas, bloating, and osmotic diarrhea, ultimately the IBS symptoms. The low FODMAP diet, or a diet that doctors prescribe where people remove FODMAP foods from their daily eating, has about a 60 to 70% effectiveness, and this is due to that decreased intestinal fermentation. What's rather interesting, though, is that FODMAPs, again, are the foods that we see are more common in our diets, such as processed food additives like sorbitol, again, lactose and gluten foods, as well as domesticated grocery store produce that has high levels of fructose that are causing sensitivities within the gut. Moving into the immune system, We started with the IBD, or inflammatory bowel disease literature, noticing that Crohn's, ulcerative colitis, and IBD conditions have been explained within a hygiene hypothesis framework. Looking at the hygiene hypothesis and the old friends hypothesis alongside some identified risk factors led us to believe that the immune system likely is an important domain, and the behaviors related to sanitation and microbiome modification should be further investigated to understand their role in irritable bowel. Irritable bowel patients oftentimes have comorbid allergic conditions like asthma, atopic dermatitis, seasonal allergies, and they show some increased sensitivities to room sharing and pet ownership. Looking at the microbiome, there's a strong selection of papers looking at antibiotic exposures throughout a variety of critical periods throughout life and their role in IBS. And there's some currently conflicting evidence looking at birth pathways and breastfeeding and how this may contribute or not contribute to irritable bowel. We're actually conducting a meta-analysis right now to try and disentangle these conflicting results and understand how these early life exposures relate to adult IBS status. Finally, the brain gut axis. IBS is sometimes referred to in the literature as a disorder of brain gut axis dysregulation. Now, I'm going to oversimplify the explanation for the sake of this talk, but within the brain gut axis, your central nervous system communicates with the enteric nervous system or the nerves lining the digestive tract. There's neurotransmitters involved, the gut microbiota plays a mediating role, the vagus nerve communicates, but essentially what's important to note here is that this feedback loop becomes disrupted within IBS patients. Depression and anxiety can signal to the gut to cause impairments of the intestinal barrier, dysbiosis, abnormal motility, leading to IBS symptoms. But then these IBS symptoms will then signal back up to the brain, perpetuating depression, anxiety, and other mental health concerns. This is something that we see in IBS patients, a really vicious cycle of depression and IBS symptoms that's very hard to break because of this feedback loop. And we'll talk about mental health in a second, but there's also some other important elements of brain gut axis regulation and dysregulation that we identified in the literature that we felt were important to investigate and look at further. One is exercise or lack thereof. Increased sedentism and lower physical activity levels associated with industrialization may lead to irritable bowel. We see that in cross-sectional studies, people reporting low levels of physical activity have higher rates of IBS. And on the flip side, with treatments, doctors are finding that prescribing yoga, walking, light exercise is actually a potentially valuable treatment for IBS patients. Something interesting to note is on the flip side, endurance athletes like marathon runners also have higher rates of irritable bowel. Secondly, we're looking at light-dark cycles, which is what we kind of coined the term to understand our behavior both during day and during the night. Now, vitamin D is a rather under-researched area of this literature, but a really promising one when one thinks about how vitamin D plays a really good role in intestinal barrier strength. I told you we looked at about 1,000 papers, maybe 10 to 20 of those looked at vitamin D. The rest were on these other domains. But patients with IBS oftentimes show lower levels of vitamin D, and vitamin D is a new novel treatment measure that some doctors are trying with IBS patients that seem to show an improvement in IBS symptoms. Then a better understood literature is the sleep and sleep disruption element of IBS. IBS patients also have strong rates of comorbid sleep disorders like insomnia, and 2 independent studies had found that prior night sleep quality was a direct predictor of the intensity of IBS symptoms the next morning. Finally, emotional stress and mental health. There are very high rates of comorbid anxiety, depression, and panic disorder amongst IBS patients. And even patients without a diagnosis of a mental illness, patients that undergo large levels of stress in their daily life are also at higher risk for IBS. There's been work done on factory workers in South America, papers investigating the rates of IBS within caregivers to relatives. All of these demonstrate, again, the role that increased stress plays within irritable bowel syndrome. Some treatment measures for irritable bowel actually include prescribing of SSRIs to kind of regulate that brain gut axis dysregulation. While in the past, fight or flight and periods of high stress and anxiety deviated energy away from the digestive tract towards more important processes, and this was beneficial evolutionarily. When we see an increased and chronic state of stress and anxiety, this is becoming detrimental to the digestive tract. Finally, just want to briefly touch on the comparative and longitudinal work that we found throughout this review, or may I say the lack thereof. No studies currently examine the 5 behavioral domains that we identified together. So a handful of studies maybe looked at perhaps the brain-gut axis as a group and looked at perhaps exercise and mental health or sleep quality and mental health and IBS. But all this work is very siloed, as I mentioned earlier. For example, if someone's less sedentary, there might be dietary reflections as well, but those links have not yet been drawn. Also, there's evidence that shows both early life exposures and current life exposures within a same domain contribute to IBS, but they haven't been examined synergistically, which is why it's essential we do some more longitudinal work. For example, with the hygiene conditions, people will look at adult hygiene environments or childhood hygiene environments, but not those together. There's also evidence that childhood trauma is a risk factor for irritable bowel, though no studies actually looked at how childhood trauma relates to adult mental health and how that relates to IBS. Finally, we see a conflation of treatment and causality in the clinical literature. This goes for almost every treatment identified within the IBS space, but I'll just use fiber supplementation as an example. Prescribers have found that supplementing a patient's diet with fiber alleviates IBS symptoms, and then these papers then conclude that if adding fiber to the diet helps IBS, lack of fiber causes IBS, though they've not yet done the work to truly identify if the lack of fiber was what was causing IBS.
Hi, everyone. I'm going to take over for a few slides here. So as Makenna came to me with this project in mind, and we started working through it, and she was going through the literature and we were categorizing and organizing it, we started to think about planning dissertation research for her and a future potential postdoc project as well. And it became increasingly clear because of some of the things she's just mentioned to you, that there were a series, go to the next slide, Makenna, of pretty significant limitations in this data. And I'm not saying they're limited to the IBS literature, but certain colleagues of mine also would argue that this is true of much clinical literature on related problems as well. So one of the challenges is that a lot of the research is conducted entirely on clinical populations, which has what I think to most of you is a pretty obvious challenge, that the people who are not having the problem, their experiences are not being included in the analysis. So we don't know if their rates of eating particular foods or not sleeping are higher than or lower than or the same as people who have IBS in the literature. So a lot of the clinical literature is suggesting risk factors, but without a control group. This is especially true in the literature on behavior. There's frequently not a control group included. And then again, we just have huge sections of people in general populations that are being excluded from this literature. The literature that is non-clinical is often demographically circumscribed, so only nurses or only students. This also creates challenges where lots of representative behaviors and experiences are not represented in the literature, and there's also small sample sizes in much of the literature. So my background is in demography, right? So I have a background in human behavioral ecology, so I come to anthropology with a very strong evolutionary perspective, but I also come with training in demography and with relevance to population health. And so this seemed to me like a pretty significant limitation. Next slide. So as we started working through this and planning future research and also writing the end of the paper that's published in Evolutionary Anthropology, we started thinking about the challenges methodologically and the fact that they really undermined our ability to test evolutionary explanations of irritable bowel syndrome. So we've been interested in combining theory with evolutionary medicine with methods from population health. We think that, as Makenna has described, the evolutionary medicine perspective is very much missing from the irritable bowel syndrome literature, and of course from some other medical literatures as well. But we're interested in seeing if we can provide rigor and trying to test some of these ideas by using some population health methodology as well, primarily focusing on making sure that we have very representative samples, just beginning by having very representative sizable samples in testing some of these ideas. Right. So go ahead, Makenna.
So with these discussions we've been having, I'd love to share just some of the upcoming survey research that we're doing for this project, addressing those limitations and trying to kind of better understand the domains that we just introduced. So the main goals of this project are to establish the evidence for these kind of industrialized behavior domains in IBS individually, but more importantly, together to understand additive effects and their relationships. And also, we're interested in clarifying the timeline of certain IBS correlates to understand upstream causality versus downstream symptomology or treatment. So for our sample, we're recruiting a representative random population sample. These will include individuals ages 20 to 65 within the greater Philadelphia area. We chose this area because it shows a really great dynamic between really rural and really urban and goes across various socioeconomic statuses, life pathways, just a really diverse group of individuals within these Philadelphia area counties. These individuals have to have been born in and grown up within the United States and have a willingness to answer some pretty personal questions about their bowel movement habits and IBS, and we're excluding individuals with inflammatory bowel disease. To recruit this sample, we're working with the Penn State Survey Research Center, recruiting them with mailers to invite them to take our online survey, and this will mimic census demographics. So we chose this method of sampling because, as mentioned, the other methods show some major limitations, like the sharply limited diversity. Rather than just recruiting people across the Penn State campus, we want people with diverse lived experiences, diverse ages, to really understand what is and what is not related to irritable bowel. By using mailers, we're avoiding issues where we might privilege those with higher SES or digital literacy if we were to recruit online. And we don't want to limit variation in characteristics of interest, which is why we're looking at this widespread group of individuals. I mentioned they'll be invited to take an online survey. This survey will ask questions about demographics and questions related to all 5 domains I just described earlier, using some validated scales and scales that we're validating ourselves because people have never asked questions quite like that before in a validated way. And we're diagnosing IBS through the survey using Rome 4 criteria. This isn't reinventing the wheel. This is the standard measure that everyone or almost everyone in IBS research uses to diagnose their individuals in population studies. Essentially, if you were to go to a gastroenterologist and describe your symptoms, they would ask you very similar questions to what's listed on this graphic here to kind of arrive at that IBS diagnosis. We're asking a few other questions to rule out some more serious illnesses like, again, IBD or cancers, things that might be common, have other common symptoms like IBS, but aren't IBS. And this whole section of the survey was formed in consultation with a gastroenterologist at Penn State Health. And as he's mentioned, this is exactly how they go through the diagnosis process in an office. Now, we have a pilot study. This was actually collected across the state of Pennsylvania rather than within the Philadelphia area. And this was just kind of a proof of concept to start to understand what's going on within people's behavior in IBS, to try and see if our questions were capturing exactly what we wanted to. So I wanted to share some of these results. We expect them to change, probably be strengthened through our future work with the actual sample strategy. But with 180 individuals, we saw 20% of them reported they were diagnosed with IBS from a doctor, and 33.5% of them were diagnosed using these questions within the Rome 4 criteria. This isn't surprising at all because IBS is commonly underdiagnosed. And I was just reading the other day, it takes a person an average of 10 years to receive an IBS diagnosis because people oftentimes just write off digestive issues as, oh, I have stomach issues, and don't take them very seriously when they are, in fact, a chronic illness. We identified 26 cases that were undiagnosed by a medical professional within that sample. And here's just some demographic breakdown. This is about what we would expect in Pennsylvania. You can see that the sample is not very diverse, sampling across all of the state right now. We hope that this will be remedied with our future approach. And then looking just at preliminary results related to those domain-specific categories. As of now, exercise is a non-significant predictor. I did my entire public health thesis on the role of exercise in IBS with no significant results at all. But we're hoping this is due to a lack of power, or perhaps, as we mentioned, looking at things individually may not actually give us the best picture of what's going on in a disease pathway. With diet, we've found that low levels of dietary fiber and sensitivities and intolerances to lactose and gluten were significant predictors. Within kind of the hygiene category, antibiotic use throughout several critical periods within the lifespan, as well as mold and dust mite allergies, came back as significant. As far as light-dark cycles, nothing yet with vitamin D, but we did see that not feeling rested when waking was a predictor of irritable bowel. And finally, with mental health, we saw strong results looking at high levels of daily stress, stress at work, daily feelings of anxiety, and then also those comorbid diagnoses with depression, anxiety, and panic disorders. Just wanted to zoom in on probably what was the strongest finding from the preliminary analyses so far, that antibiotics during a variety of periods throughout the life course are significant in predicting IBS. You can see here the odds ratios, 95% confidence intervals, and particularly under age 3 is a crucial period that we've identified. We also conducted a stepwise model selection looking at some of these significant variables so far to try and understand maybe what is the best predictive model for IBS. And as of now, we see it's lactose issues, fiber supplementation, pollen allergies, antibiotics under age 3, as I mentioned, feeling anxious, age and sex. We're building towards an information criteria model selection process for the actual data analysis with the full sample. We saw that sex was a significant predictor of IBS, with females being more likely, and there were no significant interactions, though, between sex and these predictors, and we did run some tests. As of now, these domains were not correlated.
All right, I'm just going to jump in now for the last few slides. This is exciting. I've been watching the chat and you're predicting some of the things we're discussing here. So as Makenna has discussed, and given our interest, this is a largely underexplored area at taking any kind of evolutionary approach or population health approach. So we're really focusing a particular direction, but there are other directions that you could go with this. One is a microbiome approach, and I think especially here you'd be interested in lifestyle and microbiome and variation across microbiome. We don't intend to look at this anytime soon because there's so much to be done just using survey methods, because there's so much that's unknown here that we really have some very low-hanging fruit. But I think that that's a future direction for collaboration that's of interest here. I think, as was also mentioned in the chat and is in the review paper in Evolutionary Anthropology, the genetic approaches have really shown that most of the variation in IBS does not appear to have a strong genetic component. This really looks like there might be gene by environment interactions that we could look into, but this is something where it looks like environmental components are by far the strongest drivers of variation in IBS. So gene by environment interactions is a place that someone could go as well. But for us, I think the first thing we would like to see happen is expanded behavioral data. Next slide. Mostly because, again, this has been really limited so far. So we're going to start with detailed representative survey data, as Makenna has been discussing. We're proposing a sample of about 1,000 people sampled through postcards. Again, this is a gold standard method used by demographers to get representative samples in places like the US, where you don't have HDSS sites where you can go in with a known population and sample, which is usually how I work in Bangladesh and other field sites. We're also very interested in longitudinal studies are badly needed here, but because you don't have any representative samples very much in the US, for example, to start out with at the population level, we really need to start cross-sectionally before we can move in a longitudinal direction. The longitudinal samples that exist are very small and often clinical samples, which again creates challenges. We're also very interested in moving the direction of qualitative data collection, because qualitative data collection gives us the ability to create behavior illness profiles, which is something that, again, doesn't exist in the IBS literature yet. It exists in some other literatures. And as an evolutionary theorist, qualitative data collection can be especially useful in understanding mechanism. So the proximate mechanisms whereby these larger lifestyle factors can actually contribute to actual disease risk. And especially if we combine representative survey data and then qualitative data collection, especially with people that vary across those larger population factors, which I think we'll be in a position to do once we have the larger survey data collection. I think we'll be in a very particularly good perspective to really make some headway on this. And then finally, methodologically, there's a bunch of different types of analyses, including dynamic path analysis, et cetera, that can be used to begin with a good cross-sectional, representative cross-sectional data, and then, of course, could be implemented even better if we had longitudinal data in the longer run as well. So final slide, or last slide I'm going to say something on. Okay, so just to summarize here, our approach has really taken a mismatch framework into account, focusing on industrialization, but we've tried to add to that in a couple of ways. One is by using the literature itself to expand the places in which we expect mismatch to be happening. And so we've really focused here on light dark cycles, sleep, and mental health issues in a way that I think is expanding what's been done, in addition to focusing in a more on more conventional areas such as nutrition and hygiene. And finding that, in fact, if we go to the literature first and work from the literature rather than working from theory directly, the literature is suggesting these 5 different pathways where we think industrialization really has changed circumstances and basically given rise to high rates of IBS, 20 to 30% again. We also think that some of these ideas are relevant to other, especially chronic illnesses, in which we have not yet employed evolutionary approaches. And if we start going out and looking at other things, we're probably going to find more of this. We also know that some diseases are already under investigation, and what we found has matched up well with some of that. Certainly evolutionary thinking or demographic population health methods, neither one is really being used in this literature on IBS at present. And we think that those will have, where the clinician on our team, on Makenna's committee, is especially excited about this because he sees the major gaps in the literature that can be filled by some of this work, and will be a co-author with us on several of the upcoming papers. So again, the goal here is doing what some of you are already doing to try to combine theory from evolutionary medicine with methods from population health. We really think this can enhance our understanding, especially of chronic diseases. Thanks very much.
Yeah, we'd just like to thank the people on my committee who've provided countless essential advice throughout all of this process, funding sources, and we've been doing work for outreach with the International Foundation for Gastrointestinal Disorders. And as of today, we actually had a paper come out in Frontiers for Young Minds to educate younger children about behavior and irritable bowel. So that's just the most exciting, newest thing going on with our outreach efforts. And now we'd love to open it up. I'm trying to click. There we go. We'd love to open it up for questions and discussion.
That was wonderful. Wow. Thank you, Makenna and Mary. Wow. And I'm not even gonna say anything because there's an abundance of questions in the chat, and that's wonderful. That's exactly what we want to see. There's some guy named Joe Graves. I don't know if anyone knows of him, but he's got he's got lots of comments. Joe, do you want to chime in on any of those? If you do, I'm not putting you on a spot if you don't want to.
I know,
So-
Johnny, you know me.
All right.
I would love. I mean, I just made a comment about Matthew's comment about the twin studies, which might be interesting, but given all of what I heard in that seminar, my guess is that the genetic contributions to IBS are probably very small. But we do the studies. I looked at the GWAS in Entree's PubMed before making this comment, and it looks like it's really sort of inconclusive.
This was a comment that we had gotten when our paper was under review, and we went back and looked at this literature, and that was exactly what we found from the existing reviews, and which makes this IBS a particularly interesting case study for looking at environmental effects, right? Because if genes are not particularly strong drivers, then what looks like it's happening is it's mostly variation at the environmental level, which makes it especially good for this kind of work.
Wonderful. We got a question from Tony Buffington. Tony, if you want to read your question and ask, go for it. If there's a delay, or I can read it certainly, but I wanted to give an opportunity.
Sorry, let me turn this on. There we
Oh,
go.
no
I was
problem.
just in your survey work, I was just curious as if you're going to ask about COPCs, chronic overlapping pain conditions.
We actually do have a section in the survey asking about comorbid conditions, and it does actually include chronic pain conditions as well. That's something I had learned about, not particularly through this work itself, but as I've been working with the IFFGD, they have a lot of really interesting resources about comorbid pain conditions with irritable bowel, and that was something I made sure to add into our survey.
Well, and they're particular because COPCs are chronic primary pain condition, visceral pain conditions, and that's different from just any chronic pain condition. I'm sure you're aware of that. But I would ask specifically about the 10 COPCs that have been identified as chronic primary pain conditions. In addition to others, because maybe it doesn't make any difference. Maybe they just get everything.
Yeah.
That isn't my understanding of the literature, but it's certainly possible.
We'll make sure that all of those are added. We've got a bunch of anything that the literature suggested might be comorbid is currently in the survey, but we'll make sure to double check that as we're going to be hopefully rolling this out, hopefully in the fall.
Thank you.
Thanks, Tony. Sophia Catherou, if I said that right, pronounce your name right, if you're available.
Oh, hi there.
Hi, thank you.
Hi. My question had to do with whether there is any collaboration with GI infectious disease people, because there has been reports in the literature quite substantial that some infections are sequelae of some GI infections include IBS, and of special importance in this regard is Campylobacter infections, which, Campylobacter is one of the most highly prevalent pathogens in our societies, and post-infectious IBS has been reported to be one of the consequences.
Yeah, so I've actually had conversations with our clinician, Dr. Clark, about post-infectious IBS and kind of where it falls within this project. And we've gone back and forth about this, but have at the current moment concluded that we do have questions in our survey asking about post-infectious IBS and certain infectious diseases, but for the analysis right now, we felt as though it fell outside the scope of us looking at behavioral drivers of IBS. He said that many gastroenterologists believe that there are kind of two pathways towards IBS, and one is through post infection, and the other is kind of just behavior as a whole. And also, apparently, post infectious IBS can go away after about 8 to 10 years. Apparently, post infectious IBS patients kind of, I don't want to say are cured, but go into remission and it does not flare back up again.
Thank you. There are also, as with all other foodborne infections, there are behavioral elements to Campylobacter infections. For instance, in the tendency to consume certain foods like raw milk or untreated water or poultry. So at some point, someone might have dietary habits of that type that are directly or indirectly associated with specifically Campylobacter infections. Thank you.
So we have very detailed information in the survey about nutritious factors and food consumption at this point. So hopefully we could potentially ask about things like raw milk also. Makenna, what were you going to say?
I was just gonna say, I'm very similar to what you just said, that I think that we could very easily add in some questions related to sort of those behavioral food consumption habits as well, because we do ask quite a bit already, and it would fit right in, and it would allow us, even if not investigated immediately within kind of the questions we have right now, obtaining that would be exciting for future work too.
Thank you. Could I please ask you, could you briefly elaborate how you define and understand hygiene in this context, in the context of your work?
Yes, so I will be the first to say that as a grad student, the hygiene hypothesis and the old friends hypothesis has been the most challenging domain for me to wrap my head around and understand. And I know that I've gone through very iterative definitions of what hygiene is through my reading and just trying to understand the most recent literature. But for this work, the questions we're asking related to hygiene are mainly about room sharing and being around livestock, having pets, antibiotic use, and some questions about, we're even asking about if your parents had smoked, and we're asking these questions throughout various periods throughout people's lives. So under age 3 to 12, 12 to 18, past 10 years, I believe past year as well. So those are the variables we're collecting, and we're also asking directly about comorbid allergic conditions.
Thank you. Thank you.
Thank you, Sophia. Dr. Graves has his hand raised. Thank you.
Yeah, I was trying to be polite there, Johnny. So from this very high-level conversation we're having, I'm sort of convinced of two things now. One is that IBS isn't a disease. That's more a symptom of many different diseases with many different etiologies. And that's, the same, thinking about cancer, right? Cancer has things in common, but it's actually very different depending upon which tissues it arises in. And then the second point I was going to make is that, at least from the initial data you showed about global prevalence, I don't think the hygiene hypothesis holds at all. Because if that were true, we would see some rather stark differences between the prevalence of IBS in the underdeveloped world writ large versus the industrialized world. And it didn't look that way at all. It looked like it was variable within all of those regions. So, I don't think it's a chief candidate for this.
So I've made a note of that, and I'm going to hopefully be able to capture this chat. One thing I would say to that, as someone who works in rural Bangladesh, right, which is in famous cauldron of many, many kinds of infectious diseases, especially waterborne diarrheal illnesses, is that much of the rest of the world is rapidly market integrating and rapidly developing. And so what I think is happening, one hypothesis would be, which we can't test with this data, but I think theoretically is relevant here is that societies that are rapidly integrating and they're rapidly starting to eat much higher levels of processed foods, and they're rapidly starting to go into sort of more hygiene-prone environments, and also have modern levels of stress because they're watching television and having modern jobs and on social media all the time, or really kind of going through this like life cycle, like dark cycle changes at the same time. I would say that's probably my hypothesis for why that's happening. But it's also true that the hygiene hypothesis may not be the strongest driver of this particular illness. The preliminary work we have suggests that the mental health axis is one of the really prominent ones. Makenna, did you have something you want to add about that?
No, I think what you said kind of sums it up.
Mary, we record these in the chat. I'll send that transcript to you in the email so you have
That would be
there.
fantastic because
Yeah.
we're building towards a new thing. I also want to, I already put this in the chat, but I wanted to highlight that the early life stuff is Makenna's working on a meta-analysis right now with a kind of DOHAD or early life effects framework in mind that she's going to be presenting at ISEMF. So some of y'all will see it there.
Melissa Manis, do you want to read your question or your statement? I guess it's more of a statement, but an insightful one.
Hi, Johnny. Yeah. Didn't really have a direct question, but you mean the most recent one that's in this chat, Johnny?
Yeah, sorry, I'm working my way down. Whatever you want.
Okay, yeah, I was just sort of joining. I latched on just one comment about post-infectious IBS in particular, which is a very interesting one because it brings to mind this idea of a intense trigger, right? Bringing this on. And I think for post-infectious IBS patients, most can identify a very clear trigger in a way that's maybe you've recovered, you've removed yourself from the environment, you seem to be past that infection, but it's a sense of, your inflammation and microbial changes have sort of gone through the roof and never quite come back down, right? Which sort of then opens the door to, okay, you may be post-infection or post-acute illness, but sort of the more chronic systemic things don't recover in the same way. And I think that opens the door to a lot of the environmental and mismatch and early life factors that we've been talking about, right? What are the things that happened to you in the previous years or decades that, put you in a position where once inflammation gets turned up, you can't come back down properly.
I also want to highlight the comment or dialogue between you and Joe Graves about the under misdiagnosis or kind of underdiagnosis, especially with women or those who are female identifying, and kind of posing it or as a de-stressing or managing emotions, and what Joe had mentioned about really diversifying the physician workplace is, I think that's really critical and another element to add to all of this as well. Sorry, I don't want to hijack that. I don't know if Makenna or Mary had anything to comment.
I think both things that were just mentioned there, as far as the kind of inflammation and just chronic elements afterwards, are really important to consider. And I think that's why we might not be doing microbiome work ourselves just yet, but that is why having these discussions and doing this and approaching IBS from these sort of evolutionary medicine perspectives, I think is really important. And I do think there's a lot of room for microbiome work to come, and the diversifying physicians, just as I have my MPH, it's something I'm always thinking about in the back of my head, like what can we take tangibly from these studies that we're doing and apply within the healthcare landscape. And that's something too that I think about a lot, is how females are underdiagnosed usually, but also seem to have higher rates and higher risk when we're looking at this data. So it's something I'm always thinking about. Yeah.
I'm gonna keep moving us along. Sorry, we have quite a few questions, including hand raised by Gregorios. Would you like to ask that question?
Yeah, thank you. That was fascinating. And especially congratulations to you, Makenna. I wish we had students that are so eloquently presenting things as you did. So I am a gastroenterologist. I'm a professor of gastroenterology at McMaster University. And for years, I've been trying to educate physicians in evolutionary medicine, but they're not very keen in getting that perspective, as you realize by now, by looking at the literature. I mean, we've written a couple of papers at the American Journal of Gastroenterology trying to do that. So that's a great project, but I would like to repeat what Dr. Graves said before, that it is not one disease. We call it IBS, but it is what we don't have a diagnosis for. It's probably at least 50 diseases together presenting with a few symptoms. The bowel has very limited language, like a baby that can say only 2 words, right? So whatever happens to the baby, it will say, ah. So it doesn't mean that it means the same thing. So keep that in mind. You can define all these epidemiological factors very accurately, but the thing is that the outcome, the disease, is many diseases. And the other thing is that the criteria, I mean, as you realize, they almost change continuously. You mentioned Rome 4, Rome 5 just happened recently, will be published soon. So they keep changing that. And the reason is that nobody really knows what IBS is, right? So this is good for research so that you can compare it with other studies that use the same criteria. But in clinical practice, as you will know, I mean, almost nobody uses that. So when somebody could easily have just constipation and fulfill all the criteria for IBS. And if you just don't spend half an hour with them, you'll never know that they just had constipation. So keep in mind that there will be some fuzziness about the definition of the population, no matter how accurately you identify the factors that are associated with that outcome.
Thank you. Yeah, everything you said, I think is very important for me to consider moving forward, and things I'm noticing as I'm reading and researching and doing all this is, and I love the outcome of this discussion, that it's not just one disease and that it's the outcome of many. And it's something I think is helpful to think about with IBS and perhaps even other illnesses.
I would also say that we'll see how it moves forward, but there's a chance that with this survey work, we might actually be able to look at 2 or 3 different pathways that emerge out of this and start to identify some different pathways by which some different symptomology or different diseases are essentially arising. So I'm thinking that we might be able to contribute to that as we are able to kind of statistically look at this large population survey data.
Thank you for the question, Gregorius. Matthew Jemnick, nice to see your name, and you're going to be at one of our MC participants. We're looking forward to meeting you. Do you want to, I guess, follow up on your statements that you've written?
Yes and no, I suppose. Yeah, great to see your face as well. I'm looking forward to meeting everyone next week. I think Dr. Graves really kind of captured my own thinking on it. As a behavioral geneticist, I'm curious about like twin research and adoption research to maybe inform some of our understanding of the environmental pathways, mechanisms. Although I think as Dr. Graves and I maybe have similar perspectives on the strong environmental component likely underlying this phenotype. So, yeah.
That'll be interesting. I would like to know if one of you knows when Rome 5 is coming out, because I think we want to know if we should be switching to Rome 5 in the survey. We'll see.
Barbara Winkler mentioned a comment. The Ultra Processed People book is worth a read with regard to many chronic conditions. I love that. Barbara, if you want to elaborate, please feel free, but no worries if you don't want to add on that. Just a couple seconds. How about Barnett Menon? That was a. Do you have a? Are you there? Do you have a? Can you read your question? Okay, that's okay. I can read it if he's no longer here. Barnett's question was, or statement was, Dutch pediatricians often do not use antibiotics for otitis media in toddlers. Would be interesting to see if they have lower levels of IBS in other European countries.
And they've stayed away from antibiotics. This is not new. The Dutch have not used antibiotics perhaps for 40 years in otitis media, and which is, of course, I'm sure you know, the most common reason for antibiotics in toddlers. So it might be interesting to look at the incidence of IBS in the Dutch now compared to the Belgians and the French and the Northern Germans, etc.
Definitely.
That's an interesting idea. My sister-in-law is a Dutch physician, although she works in France. Unfortunately, she is a neonatologist, which doesn't help with this particular study, but I could probably get her perspective on the kind of data one could get.
I think we might have time for one more question, but if people want to kind of peel off, understood. We will upload this talk in about a couple of hours onto our YouTube page and our website as well. But if we have one more question, I'm hoping, let's see here. Matthew already went, Joseph's a bit. How about Jay Moltzow? Are you there? So Jay wrote, your data suggests a strong role for a disturbed microbiome during key early life immune priming development. That was interesting as well. If you have a last comments on it, if anybody wants to add to it, that would be great. And then we'll wrap it up.
I would just say, Oops, sorry. I was just going to say, we've had those discussions that we also think the data is suggesting this kind of key early life period.
I've added in the chat, Makenna is going to be presenting an early life focused meta-analysis at ISEM this year. And so hopefully that will start to give us some headway on this, even though she's not looking at the microbiome itself, but we're looking at potential triggers from early life.
This is fantastic. Thank you all. We are past the hour, so we're going to close it off, but I will follow up with Mary and Makenna as well as Joseph on some of those questions. Thank you all so much. We will hopefully see you in July sometime for another virtual session, and then after that in August for ISEM. Thank you, everybody. Thanks so much. This was great.
Thanks so much.
Thank you, everybody.
Fantastic talk. Bye.
Thanks, Charlie. We'll hopefully see you in the fall.
Yes, and in the summer.
And in the summer too, right, exactly. And in the summer too. This will be exciting. Please don't forget to send the chat. There's no way I could keep up with that. And also,
no, I will follow up right after this.
No, that's great. No, yeah, we really need to go through it and make sure we're
some good stuff
incorporating what we can. Yeah.
Absolutely. Thank you.
Bye.